My name is Dr. Bonnie Key, and I'm the Founder's Associate Professor of Cardio-Oncology at the University of Pennsylvania, and I'm also the Editor-in-Chief of JACC Cardio-Oncology. I wanted to congratulate the VCOS organizers and the symposium directors for a truly wonderful meeting, and welcome all of you to our next session. I'm here with my co-chair, Dr. Daniel Lenihan, who really needs no introduction. He directs the Cardio-Oncology Center of Excellence at the Washington University, and he's also deputy editor of JACC Cardio-Oncology. I'm pleased to open the session today on biomarkers and cardiovascular imaging techniques for cardio-oncology and introduce our first speaker to you, Dr. Daniela Cardinale. She has been a long-standing leader in the field of cardio-oncology and really been a true inspiration to all of us. Today, she'll be talking to us about improving our insights, biomarkers in daily practice. Daniela?
Thank you, Bonnie, for the introduction. So, dear Bonnie, dear Daniel, Susan, good morning. And Teresa and Jose, for you, good afternoon. So, hi, everybody. Thank you for the kind invitation. These are my disclosures. Okay, in the oncologic setting, the evaluation of cardiac biomarkers can be of help in early diagnosis of cardiotoxicity, cardiac risk stratification, cardiac event prevention, and cardiotoxicity treatment. For once, I will not speak about early diagnosis of cardiotoxicity, my favorite setting, as you well know. And I will start by showing you our experience of using NT-proBNP in predictive and preventive post-operative atrial fibrillation in patients with lung cancer. Post-operative atrial fibrillation is a frequent arrhythmia after lung cancer surgery, and its incidence rises with extension of surgery. And although self-limited in most cases, its treatment required additional costs for care and prolonged hospital stay, even when not complicated. Acute complications may include hemodynamic instability, heart failure, acute coronary syndrome, and stroke. And after discharge, it is associated with a higher ischemic stroke rate within the first year. Many risk factors have been indicated, particularly in the cardiac surgery setting. However, a clear link between them and the occurrence of this arrhythmia has not been well established. Regarding biomarkers, increased natriuretic peptide levels have been described in patients developing atrial fibrillation after cardiac surgery. So, to evaluate the role of NT-proBNP as a possible marker for restratification of post-operative atrial fibrillation in the setting of lung cancer surgery, we perform a prospective clinical study including 400 patients, and we measure NT-proBNP concentration 24 hours before surgery and 1 hour after surgery. So we found elevated NT-proBNP value in 22% of patients. Patients with elevated NT-proBNP were older, more likely to have had a history of coronary artery disease and a chronic pulmonary disease, a worse renal function, and worse pulmonary functional text. After surgery, the incidence of atrial fibrillation was 64% in patients with elevated NT-proBNP versus 5% of patients with normal NT-proBNP value. At multivariable analysis, after adjusting for confounders, both preoperative and postoperative NT-proBNP values were independent predictors of postoperative atrial fibrillation. Notably, the negative predicted value was high, 93%. Our next step was to perform a prospective randomized trial to assess whether a prophylactic treatment with either metoprolol or losartan reduces the incidence of arrhythmia in high-risk patients selected according to elevated NT-proBNP value. we screened 2,041 patients, and we assessed NT-proBNP in 1,116 patients. So the final population was 320 patients. And this patient with elevated NT-proBNP, and this patient were randomized to receive metoprolol, losartan, or placebo. So overall, atrial fibrillation occurred in 9% of the overall population. But in NT-proBNP high level, the incidence was 20% versus 4% in patients with normal NT-proBNP. And the randomized population, the incidence of arrhythmia was significantly lower in the two treated groups, with the lowest incidence observed in metoprolol treated patients. Patients of the control group, those with the highest percentage of episodes of atrial fibrillation, showed a longer postoperative length of stay and experienced a more complicated in-hospital clinical course. So our study conclusion were that in patients with elevated NT-proBNP level at high risk for atrial fibrillation, prophylactic treatment with metoprolol or losartan initiated soon after lung cancer surgery was well tolerated and significantly reduced the occurrence of atrial fibrillation and cardiovascular events. Another possible use of cardiac biomarkers in the clinical cardio-oncological practice is the treatment of cardiotoxicity, in particular in the management of patients with cardiotoxicity induced by trastuzumab. We well know that trastuzumab can induce a symptomatic decline in ejection fraction or heart failure in up to 25% of treated patients. In contrast to anthracyclines, cardiotoxicity induced by trastuzumab typically manifests during treatment. And this can result in incomplete breast cancer therapy and an increase in cancer recurrence. So, cardiac safety of continued trastuzumab in patients with asymptomatic ejection fraction decline is a no, because no randomized trials proved that heart failure drugs may improve cardiac function, allowing resuming and completion of trastuzumab therapy. So to evaluate the impact of a cardio-oncological approach in terms of the adherence and continuation of oncological therapy with trastuzumab, we conducted a small retrospective studies that include 84 HER2-positive breast cancer patients with an ejection fraction decline and below 55%. 57 patients received a cardio-oncology managed approach that include a strict control of cardiovascular risk factors, a prompt initiation of IC inhibitors and beta blockers, possibly in combination, electrocardiogram, echocardiogram every month after resuming, and troponin BNP at each cycle, and heart failure therapy was managed according to troponin and BNP values. Clinical data were timely shared with oncologists. On the other hand, 27 patients received a standard care management in which stop and resuming resumption of trastuzumab, time to initiation of ACE inhibitors and beta blockers, electrocardiogram and echocardiogram schedules were at the description of the treating oncologist or cardiologist. So we didn't find significant difference in terms of cardiac risk factor, cardiologic history, or oncologic history in the two study groups. All patients of the cardio-oncology group resumed and completed trastuzumab. Conversely, no patient of the standard care group, even those who improved their cardiac function to above 50%, resumed trastuzumab. And the decision not to resume trastuzumab was oncological in 55% of cases, because of ejection fraction less than 50% in 19% of cases, and for patients' choice in 26% of cases. Ejection fraction at baseline was normal and in each study groups, and ejection fraction at nadir was significantly lower in the standard care groups. Final ejection fraction was significantly higher in cardio-oncology group, and even if they resumed and completed trastuzumab treatment, this patient received more frequently a cardioactive therapy with ACE inhibitors and beta blockers, possibly in combination. And we observe a difference regarding the total number of cardiac events, 26% versus 10%, even if but the difference was not significant. Importantly, overall survival and oncological survival were significantly better in the cardio-oncological managed group who completed trastuzumab therapy. So our study conclusion is that a targeted cardio-oncological approach allowed the resumption and the completion of trastuzumab therapy, contributed to a higher number of patients with normal or near normal left ventricular ejection fraction, with a reduced number of cardiovascular events, and it was associated to a better oncological outcome. Study limitation are that we included a small population at the retrospective design, but the strong point is that this data come from the real clinical work. And now we are waiting to know the result of this pilot trial, whose objective is to prospectively evaluate the cardiac safety of HER2 targeted therapy in patients with breast cancer and the reduced left ventricular ejection fraction with optimized cardiac therapy. And this patient will be followed by serial echocardiograms with strain, clinical visit, and the assessment of troponin I and troponin T. Given the implication of trastuzumab therapy completion, in my view, any information about the management of this patient will be very useful to know. Thank you for your attention.
Thank you so much, Daniela. As always, your slides are always entertaining and very informative. So it's always a great pleasure to see you, and thanks for your presentation. Next, I want to introduce our next speaker, who's going to talk about the role of advanced cardiac imaging in the prevention of cardiotoxicity. And this is Juan Carlos Plana, who's the Chief of Cardiology at Baylor College of Medicine in Houston, and a lifelong great friend, and it's great to see you. Take it ahead.
Thank you, Dana, and thank you to Teresa and all of the organizers of this phenomenal meeting. So what I want to do, let me make sure that I can advance this. Okay. So what I want to do in the next few minutes is to really review with you a couple of studies that have generated a lot of traffic and attention in social media. The first one you have over here, the tweet from Federico Ash, describing breaking news and a critical finding, reporting on a study that he had the opportunity of leading, the WAIS study, where they are reporting on new values of normal ejection fraction, 57% for male and 58% for females. We're going to go in a little bit of detail afterwards. And then you have one of my colleagues over here in Houston, Dr. Garcia Sayan from next door at the University of Texas, asking us to the implications of these findings for cardio-oncology guidelines and the lower limit of normal that we have been using. And then second study, a study that we have been waiting for quite some time, that was presented in the European Society of Cardiology by Dr. Negishi. Dr. Thavendiranathan has been a lead on this study. We only have right now the abstract and the presentation that Dr. Negishi gave. But what I want to do is I just want to review what we know so far about the study. And obviously, we're very anxious to see the final publication. So this is my outlook. So let's go ahead and get started. I think that let's start talking about risk stratification and the impact of this study from Federico Ash. So let's go back in time. Back in 2014, when I was finalizing the expert consensus on behalf of the American Society of ECOM and the European Association of Cardiovascular Imaging, initially we had set up the threshold of abnormality and therefore the definition of cancer therapeutics related cardiac dysfunction using a lower limit of normality of 55%. One of the exercises that you need to do when you are about to publish a guideline is, first of all, you need to make sure that this is not going to be discrepant with any guideline that has been produced or any guideline that is coming down the pipeline for the American Society of ECHO. So when we were about to publish it, I received a call from Dr. Lang, and he mentioned to me that he was going to come with a revised version, with a 2.0 version of the chamber quantification guideline, and that the lower limit of normal was not going to be 55%, but was going to be 53%. And therefore, the expectations from the American Society of ECOM is that I will adjust the definition of cancer therapeutics related cardiac dysfunction using this lower limit of normality. So right now, moving forward to the publication of this document, the WACE study, you realize that they are reporting on a much higher lower limit of normal. What they found in this study, and this was incorporated a population from all over the world, Asia, Argentina, Mexico, the United States, among others, they found a lower limit of normality for males of 57, upper limit of 68, for females 58, upper limit of 69. And as you can see, and in the right side of the slide, you have the historical normals from the ASTEA CBA guidelines, much lower, 52 to 72 and 54 to 74. Very helpful. They actually also evaluated global longitudinal strain in this population. So we have a definition of normals. And for males, they are describing minus 17 to minus 24. And for females, minus 18 to minus 26. So the question is how do we put this with the information that we know, and is it discrepant to our current knowledge? I will probably convince you that that's not the case. I love this study, the 7-year follow-up of the NSABP, where they actually tell us and guide us in our understanding of the risk factors for cardiac events, which in this particular case were death and symptomatic heart failure. And they actually tell us that if we use the very simple mathematical calculation at the bottom, where you need to plug in two variables, the age of your patient and the baseline left ventricular ejection fraction, you will be able to predict the risk of cardiac events. I want to get your attention, if you take a look at baseline ejection fraction, which is what is our topic of discussion right now, how if they use a baseline ejection fraction of more than 65%, and if they compare it to patients that start treatment between 55 to 64, how the hazard ratio will go up almost by 2. And how, if you compare this group to patients that will start with an ejection fraction of 50 to 54, the hazard ratio will be 6.7. The same phenomenon apply when you are about to start trastuzumab after anthracyclines, and you go by a factor of 3.5 and by a factor of 11.8 when you compare patients in the 50 to 54, 55 to 64 versus the reference value of 65. So really what you see here is that it's a continuum. Patients between 55 and 64 will do worse than patients that start with 65, and obviously patients that start with ejection fractions of 50 to 54 will do much worse as compared to the previous two groups. You see over here two examples, a patient that is young, 45 years old, that starts with an ejection fraction of 65%, and you see over here that the predicted probability is very low. The risk of events is 2%, while if you evaluate a patient that is 65 and that starts with an ejection fraction of 55, the predicted probability is almost 12%. My colleague, Marielle Cheddar-Crosby, evaluated this concept in a study, the one that you have in front of you, 2,800 patients. And she's able to tell us exactly the same message. You see over here a Kaplan-Meier curve for MACE-free survival, comparing three groups of patients between with ejection fractions of less than 53, ejection fractions from 53 to 58, and patients that started with an ejection fraction of more than 58. And you can see how there is really a continuum of risk depending upon your baseline ejection fraction. In this study, she uses global longitudinal strain. And if you compare in table 2, the global longitudinal strain of the patients that didn't have events versus the ones that did, you see a significant difference, minus 19.7 versus minus 15. So much that she was actually able to create a Kaplan-Meier curve where if your global longitudinal strain is more negative than minus 17.5, and remember that this is very consistent with what the WACE study was telling us, you are really not going to get into trouble. I mean, you see that the blue line is absolutely flat. While if your global longitudinal strain is less negative than minus 17.5, you see that those are the patients that are going to have events. Of note, if you take a look at figure 3, it has an added value when you compare it with clinical variables and clinical variables with left ventricular ejection fraction, letting us know that you are further characterizing the patient and further risk stratifying them when you add the evaluation by global longitudinal strain at baseline. Now, I think hopefully I have been able to convince you that there is a continuum of risk for left ventricular ejection fraction at baseline. But I think that what is complicated is that we will need to draw a line in the sand somewhere as to what is that we're going to use as lower limit of normal to migrate patients from a stage A to a stage B heart failure, which at the end of the day is what really matters because it has implications in management. Once you fulfill the definition of a stage B heart failure, this is when we are going to be starting beta blockers and ACE inhibitors. So let's move to the second part, early detection of LV dysfunction. And I think that obviously we need to talk about the SUCCORE study. So what is the SUCCORE study? It's really a comparison of two strategies for adjudication of a stage B heart failure. To the right, you have the conventional one, where you're going to look for a drop of 10 points of ejection fraction. This is kind of the same criteria that we use for cancer therapeutic-related cardiac dysfunction, although, as you remember, in our case, we mandated that the ejection fraction needed to be less than 53%, lower limit of normal, and I already told you the story behind it. And then the strategy in the left, which is the strategy using global longitudinal strain, looking for a percentage reduction when compared to baseline of 12%. And then the endpoint of this study was left ventricular ejection fraction calculated at 1 year of follow-up using 3D echocardiography. There was two secondary endpoints that were included. The first one is the amount of patients that fulfill the definition of cancer therapeutic-related cardiac dysfunction, a drop of 10 absolute points of ejection fraction below a left ventricular ejection fraction of 55%, and also the comparison of the ejection fraction among the two groups that were actually treated. So you see over here, and I'm not going to stop here, you have this information in the abstract, the age and risk factors No surprise, significant amount of risk factors. You can see 30% hypertension, 24% hyperlipidemia, kind of the patients that we are used to see in our clinics. Most of them, obviously, were getting anthracyclines and trastuzumab, so of no surprise, most of them got it in the setting of breast cancer treatment. You have over here the echo parameters. You realize that the core lab measurement was a bit lower than what was calculated in the sites, 61 versus 58%. And let's go over the results. So the primary endpoint, they didn't find a difference in left ventricular ejection fraction between the two strategies. It was a bit lower on the ejection fraction side, 55 plus minus 7 versus the left ventricular ejection fraction strategy with a p-value right at 0.05. Now, when you compare the secondary endpoints, there was a difference. You can see over here that the amount of patients that fulfilled the definition of cardiotoxicity was 9 versus 21 in the EF guidance strategy with a p-value that was statistically significant at 0.02. And also, there was a larger reduction in the left ventricular ejection fraction in the group of patients that had EF guided cardioprotection versus the ones that had the strain guided cardioprotection, 9.1 versus 2.9%. So the authors conclude that although the change in left ventricular ejection fraction was not different between the two arms, GLS guided cardioprotection significantly reduced a meaningful fall of left ventricular ejection fraction to the abnormal range. They claim that the results support the use of global longitudinal strain in the surveillance for CTRCD. Now, what are the implications? We have Daniela Cardinale in this part of our conference. She has emphasized the importance between the end of chemotherapy, left ventricular ejection fraction, and the cardiotoxicity development. So I think that seeing that these patients are seeing that there are less patients that are fulfilling the definition of cardiotoxicity, and that these patients have a higher ejection fraction when we have used the strain guidance for the initiation of cardioprotection, I see it as appealing. But I have had lengthy discussions with Dinesh, and really I think that we will be able to convince the community in the moment that we move beyond an imaging endpoint as 3D ejection fraction, the one chosen in this particular case. I think that what the community wants to see is they would like to show us a difference in mortality, a difference in heart failure admission. And as we collect this data, which could be difficult, I think that probably they will be interested in the meantime in seeing difference in surrogates of this information, like exercise tolerance and VO2 max. So what are the conclusions of my talk? The higher the baseline left ventricular ejection fraction, the lower your risk of cancer therapeutic related cardiac dysfunction. The reduction in ejection fraction really presents a continuum of cardiovascular risk. Global longitudinal strain has an added value in the risk stratification of patients at baseline. At 1 year of follow-up, the use of a strain-guided results in a reduced number of patients with cancer therapeutics related cardiac dysfunction and with a higher 3D left ventricular ejection fraction when compared with the EF guidance strategy, and further data is needed on the impact of the strain-guided strategy on harder cardiovascular endpoints. And with that, I thank you for your attention.
Thanks so much, Juan Carlos, and a truly excellent presentation and gives us motivation for how we can move forward. We'll take questions at the end, and I'd like to introduce our next speaker, Dr. Dinesh Thavendiranathan, who will talk to us about how CMR may help. Dinesh?
Thank you very much, Bonnie. I'd like to start by thanking the organizing committee for the invitation. It's a pleasure to be here. These are some of my disclosures. So today I'll discuss the role of cardiac MRI in cardio-oncology, and I'll focus on 3 main applications. The first is to promote understanding of ventricular and vascular remodeling during cancer therapy. Second, to promote accurate diagnosis of cancer therapy-related cardiovascular dysfunction. And finally, for prognostication of future cardiovascular disease. I'd like to highlight up front that the existing literature with the use of cardiac MRI has focused on anthracyclines and HER2-targeted therapies, and hence my presentation will reflect that as well. And today I'm not discussing the role of cardiac MRI for assessment of cardiac masses. Let's start by understanding ventricular and vascular remodeling. In patients who have received anthracyclines or trastuzumab-based therapy with accurate and reproducible measurements of left ventricular volumes, we've been able to show that almost universally there's an increase in end diastolic volume and end systolic volume in patients receiving these therapies. Now, a larger increase in end systolic volume than end diastolic volume results in a fall in left ventricular function. But more recently, we have also learned that a reduction in end diastolic volume, perhaps due to intravascular volume depletion, may also result in a reduction in left ventricular function, emphasizing the importance of looking at the changes in ventricular volumes when we identify patients who have a reduction in ejection fraction. There also seemed to be a simultaneous change in right ventricular parameters in patients receiving anthracycline-based therapy, both volumes, as well as a simultaneous reduction in left and right ventricular ejection fraction. It's also interesting to look at what happens to left ventricular mass. Patients imaged 6 months after initiation of anthracycline-based therapy seem to have a reduction in left ventricular mass associated with a reduction in left ventricular function, an increase in myocardial wall stress, and a reduction in ventricular arterial coupling. What was interesting was that this change in left ventricular mass seemed to be associated with a change in heart failure symptoms. Now, this finding of change in left ventricular mass has not been consistent in the literature, but at least let's go with this and let's look for potential cause or explanation as to why there may be a reduction in left ventricular mass. We can use pre and post contrast T1 mapping to calculate extracellular volume fraction, which is a marker of space outside the myocytes, and intracellular lifetime of water as a marker of myocyte size. In anthracycline-treated patients, although a small cohort, there was an increase in extracellular volume fraction, but a reduction in myocellular size, suggesting perhaps this reduction in left ventricular mass may reflect myocyte atrophy. However, in a carefully done control study in a primate model treated with anthracyclines, imaged again 6 months after initiation of anthracycline, there seems to be a reduction in left ventricular function, but an increase in left ventricular mass, extracellular volume fraction, and T2 values. And on histopathology, there was an increase in collagen fraction, a reduction in the number of cardiac myocytes, but an increase in the cross-sectional area of the remaining myocytes that may have contributed to the increase in left ventricular mass. If we continue to look at this a little bit closer with more comprehensive tissue characterization with T1 mapping, ECV, and T2, again imaged about 3 months after initiation of anthracyclines, there seemed to be an increase in myocardial T1 values, ECV, and T2 values, which were not seen with anthracycline-based therapy. Now, when we examined this in a smaller cohort of women with HER2-positive breast cancer treated with anthracyclines and trastuzumab, much lower dose of anthracycline therapy, again, there seemed to be an increase in myocardial T1 values, T2, and ECV in patients who developed cardiotoxicity. So this literature seems to suggest that early myocardial injury may be reflected by potentially myocellular edema, extracellular edema, with or without interstitial fibrosis, and possible changes to myocyte size. Now, the impact of these therapies on the system extends beyond just the cardiomyocytes to include vascular remodeling as well, something that has been also nicely demonstrated with some studies in anthracycline-treated patients. You can see that with using phase contrast imaging, there was a reduction in pulse wave velocity, as well as using the cine component of this, there was a reduction in distensibility of the ascending aorta as well, just within 4 months of initiation of anthracycline-based therapy. And what was striking was that this change in pulse wave velocity was equivalent to about 15 years of aging of the vascular system. Now, moving from the remodeling aspects that can be identified by cardiac MRI, the second potential application is to improve diagnosis of cancer therapy-related cardiovascular disease. Now, most of you are familiar with the study in pediatric cancer survivors with the cardiac MRI performed when EF less than 50% was used to define subclinical cardiomyopathy. Other echo imaging modalities seem to miss a subgroup of patients, resulting in some degree of misclassification. Similarly, when we followed women with HER2-positive breast cancer with repeated cardiac MRI and echocardiography every 3 months during cancer therapy, we were able to see that more patients met criteria for cardiotoxicity by cardiac MRI than 2D echocardiography measured ejection fraction, suggesting that if you're only using an EF-based approach with echocardiography, there may be a subgroup of patients who may be misclassified during their cancer therapy. And I truly believe where cardiac MRI will have a significant impact is in the assessment of immunotherapy-related myocarditis. Dr. Neelan and others have shown that in the context of immune therapy, specifically ICI-related myocarditis, majority of these patients have preserved left ventricular function, emphasizing the importance of looking at changes to the myocardial tissue. And I'm sure most of you are familiar with the updated Lake-Lewis criteria in 2018, which suggested that you need to meet two main criteria for the diagnosis of myocarditis. One was the presence of myocardial edema, and the second is the presence of non-ischemic myocardial injury. Now, this was examined in a group of patients with immune checkpoint inhibitor-induced myocarditis, and the traditional sequences were used where late gadolinium enhancement and T2 weighted imaging was used to assess for the presence of myocarditis. As you can see here, a significant proportion of patients met either one criteria for myocarditis, but it was very uncommon for patients to meet both main criteria for the diagnosis of ICI myocarditis. And Dr. Neelan was also able to show that from a prognostic perspective, neither late gadolinium enhancement imaging or T2 weighted imaging identified those patients who subsequently developed MACE. But where I think cardiac MRI will shine is when we can use quantitative tissue characterization parameters. So on the left-hand side, you have a patient who presented to our site with suspected ICI-related myocarditis. Our scanner normal values are shown at the bottom left, and you can appreciate an increase in myocardial T2 values that were regional, but a remarkable increase in myocardial T1 values, hence meeting both the main criteria for the diagnosis of myocarditis. We brought this patient back 6 months later after they had completed their steroid therapy to repeat the imaging. And as you can see, a nice response in a decrease in T2 values and a remarkable reduction in myocardial T1 values, suggesting that these quantitative techniques may not only help with accurate diagnosis of ICI myocarditis, but potentially to monitor response to therapy. And you'll be seeing some data forthcoming with the use of these techniques in ICI myocarditis. The last concept I want to speak about is prognostication of future cardiovascular disease using cardiac MRI by early detection of cardiovascular injury. As you heard from Dr. Plana, we have had a lot of data that has suggested that an echo-based strain can identify those patients at future risk of cardiovascular disease. We have not had much data along these lines with cardiac MRI, but we have seen a lot of data using cardiac MRI that suggest a change in strain does occur early during cancer therapy, but we had not seen prognostic data. So this year, there were 2 papers that looked at the prognostic value of strain. We looked at 125 women with repeated imaging every 3 months with cardiac MRI, and we measured strain 2 ways, both using tagging-based approach as well as the feature tracking-based approach. And we looked at an absolute change in strain and a relative change in strain to prognosticate cardiotoxicity during cancer therapy. And we were able to show that a relative change in strain was perhaps better than an absolute change in strain to identify those patients at risk of cardiotoxicity, similar to what we have seen with echocardiography. It was also interesting that, similar to another study by Dr. Greg Hunley's group earlier this year, left ventricular end systolic volume increase was also prognostic for subsequent cardiotoxicity, and it may be a surrogate marker of changes to myocardial contractility. Another thing that I want to point out on the right-hand side of the slide is that there is a continuous relationship between the degree of relative change in the measure of strain, regardless of what measure is used, and the risk of cardiotoxicity. And higher the change, the higher the risk of cardiotoxicity. So in moving away from just a binary threshold, there seems to be a continuous relationship between change in strain and subsequent risk of cardiotoxicity. There's been also a lot of excitement in using tissue characterization techniques. And this paper earlier last year really raised some excitement. In an animal model where doxorubicin was injected through the coronary system, this study demonstrated that there was an earlier increase in myocardial T2 values, suggesting edema, before a fall in left ventricular ejection fraction. What was interesting is when they identified an increase in myocardial T2 values, when they stopped doxorubicin-based therapy, they were able to preserve left ventricular function, suggesting that T2 measurements may be a good marker of early myocardial injury. But clinical data along these lines have been quite limited, but 2 papers, one last year, one this year, that has really provided us a snippet as to how we can potentially use this. In a small group of anthracycline-treated patients, those who developed cardiotoxicity had a larger increase in myocardial T2 values early during their chemotherapy compared to those patients who did not develop cardiotoxicity, and a significant increase in T2 value had good discriminatory value and good sensitivity for future development of cardiovascular events, although the scanner information was not provided. Now, the timing of imaging seems to be important because this is another study of anthracycline-treated patients where patients were imaged within 48 hours of initiation of anthracycline-based therapy. Here, there were no changes in myocardial T2 or ECV, but a remarkable reduction in myocardial T1 values, and the rationale for this still remains to be elucidated. So in wrapping up, in summary, I think hopefully I've shown you that cardiac MRI does have a role in cardio-oncology. It helps with improved understanding of ventricular and vascular remodeling, hoping that it'll help guide primary prevention therapeutics. It provides more accurate diagnosis of cancer therapy-related cardiovascular dysfunction, hopefully allowing early diagnosis and intervention and ultimately less interruption of cancer therapy. It promotes early detection of cardiovascular injury, which could be prognostic, and we could use this to guide screening strategies with our more routinely available technology and perhaps institute upfront treatment to prevent the development of cardiovascular disease. I think I've also pointed out from the beginning that there's existing data in this field is quite limited, and it's really been limited to anthracycline-based therapy, but there are many ongoing trials which will inform, I think, the clinical value of cardiac MRI. And finally, as we evolve in cardio-oncology, cardiac MRI sequences have evolved quite significantly as well. And there's going to be more rapid imaging and more rapid post-processing that's going to be available, which would make cardiac MRI, I think, more attractive for routine clinical use in the future. Thank you.
Thank you so much, Dinesh, and also Daniela and Juan Carlos. As always, 3 excellent presentations, which in essence really bring up many questions, as we've seen from our chat room. There are a number of questions, so I'm going to pose a couple of them. The other thing I wanted to make sure everybody understood is that we have 2 satellite sessions that are not on the actual agenda. They're supplementary, and they are available for you to view whenever it is a convenient time. These will be focused on much more detail, one for echo imaging and the other will be based on MRI imaging. So I'd encourage you to look at those satellite sessions when there's an opportunity. So to get straight to the questions, there was a question from Dr. Fuster to Daniela, and basically the question was, when is the proper timing for troponin measurement after chemotherapy infusion? Okay, we'll get back to Daniela. Oh, there she is. So you're muted, Daniela. How about we'll come back to that one. And then Juan Carlos, the one question came about, based on partly on what you showed, is it time to get rid of LVEF as a measurement of cardiotoxicity based partly on what you presented, but other data in regards to strain as being useful?
Okay, thank you for the question.
Yes. Yeah, so Daniela, if you could address the question, what's the proper timing of measuring biomarkers after cancer therapy?
Seems like Daniela still may be having problems, so maybe we should go back to Juan Carlos.
Sure. Dan, I can go ahead and answer my question while Daniela sorts out the technical difficulties. Is that okay?
Yep, absolutely.
All right. So I don't think that I'm going to leave.
Okay, we measure eye sensitivity troponin immediately before and immediately after chemotherapy infusion. The best time. Okay.
Yes, we can hear you.
Okay.
So Daniela, basically you measure it immediately before and immediately after infusion.
There is an overlap of voices. Okay. Okay. What I have to do?
I think maybe while Daniela continues to sort out, we should move on. And
Exactly. And the best time. There is, okay. The best time would be 24 hours later, but from the organization point of view, it's not possible because the patient go home immediately and maybe take an airplane to, in many cases. So, but we need. Okay. Okay. I stop.
Okay, thank you very much. So Juan Carlos, do you want to finish out there?
Yes, but it's impossible because the patient.
Okay, Juan Carlos, you want to try it again there?
Sure. So the question that I was asked is, are we ready to give the farewell to the ejection fraction and only use global longitudinal strain? I don't think that is the correct approach. As I was able to show, if we take a look at the two scenarios that I review, in the baseline stratification, ejection fraction, something very easy to measure, has a very important prognostic value. You remember the mathematical calculation that I showed you for something very simple. You just need to plug in the age and the left ventricular ejection fraction of your patient. Now, from the data from Ariel, you learn that global longitudinal strain actually has an added value in the risk stratification when you take into consideration clinical variables and ejection fraction. Now, in the surveillance of cardiotoxicity, I think that global longitudinal strain is a more sensitive measurement than ejection fraction. And also we have learned that it is probably more reproducible. So I think that towards the future, and you also saw the data from MRI, I think that this is a good strategy that you can use to do surveillance. But I don't think that we are ready to kiss goodbye to ejection fraction.
Great. And then Dinesh, there were a couple of questions, but one was specifically about T2 imaging. Is that useful for anthracycline-based cardiotoxicity as opposed to just immune checkpoint inhibitor-related myocarditis?
Yeah, I think that's a good question. I think that remains to be seen. If you look at the literature, it has been inconsistent, and the signal has sometimes been there in some of the anthracycline-treated patients where you would see an increase in T2 values, but often you would see an increase in T2 values, when you're measuring, when you're getting a septal measurement as opposed to a global measurement. In our cohort, we also see an increase in T2 values. My concern is that the degree of change in T2 values are probably going to be small, and it may just not be accurately measurable. And I think we'll probably see a better signal with T1 and possibly extracellular volume fraction than just T2 mapping. But that remains to be determined. Several ongoing studies that are looking at that, and we'll hopefully have some results within the next year to see if T2 is valuable post-anthracycline therapy.
Great. Bonnie, I don't know if you have some questions you would like to ask.
no, I thought they were all very excellent presentations. I guess one question I had for the group is really what is your go-to imaging modality? If in just, I know Dinesh particularly has interest and expertise in echo and MR. Is echo still your first go-to? And for Juan Carlos, are you, with echo, how are you decreasing variability in many of the measures and improving reproducibility?
I guess I can start because you mentioned my name first, Bonnie. So I think, with our lab, it's about availability, right? And I think echo is still the go-to method. I think having spent time over the past 5 years using both modality in all my patients as a method of learning within clinical studies, with respect to detection of abnormalities, I think cardiac MRI seems to outshine left ventricular ejection fraction. But I think from a practical perspective, echo is still better. And ultimately, the question is, we're seeing all of these changes. Does it really matter? I.e., is there a downside to missing some of these patients? Does it have implications for patients? I think that remains to be seen, to be honest.
Certainly hard endpoints, hard outcomes, as Juan Carlos eloquently detailed.
So, Bonnie, in terms of reducing variability, actually in our lab, we use the manuscript that Dinesh wrote, with Dr. Marwick in terms of the lessons that they learned from the support study. There is a learning curve, when you are using global longitudinal strain. There are technical mistakes that you can avoid. For instance, including the mitral annulus, going into the left ventricular outflow tract, being generous and also capturing the pericardium, or going on the opposite direction where your area of interrogation will be too thin and you're going to be missing some of the global longitudinal fibers. So what we have done is we have actually reviewed the examples that they use in the JACC publication, and I think that we do much better with that quality. We also have a review and peer review of our cases, so we keep eyes, on what all of us are doing. And this is very important because, again, you don't want to blow the whistle of cardiotoxicity just because you're making a mistake, just like I just mentioned, with the calculation of global longitudinal strain.
Bonnie, I also think that, imaging, of course, as was just discussed extensively, imaging is obviously a cornerstone of what we do, but, biomarkers are equally as important in other ways. And I think especially if you put it in the context of COVID, we have really proposed that instead of intensive imaging, that perhaps a biomarker approach would be a very reasonable strategy. So I think that all of these tools have their place for sure, and I think that we need to find out how to best apply those tools in a manner that prevents hard cardiac endpoints like Juan Carlos was presenting.
Excellent points by all. And just want to congratulate all the speakers and just thank you for your excellent presentations. Take care, everyone.
Very good. Thank you all so much. Appreciate all your effort.
Thank you.